Webinar, Wellness Agency and Sanity, How to Cultivate Community in Your Clinics. I'm Stephanie Adler-Yuan, Director of Education and Training here at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, I'd like to go over a few details about the webinar. First of all, the Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes long. The first 45 minutes will consist of a presentation, and then we'll follow that with 10 minutes of question and answer, during which all of our participants are welcome to ask questions of our speakers. Today's program is being recorded, and it will be available on the Schwartz Center's website in about a week after the session. Please note that as attendees, you are all participating in listen-only mode, but you can interact with our speakers, and we encourage you to, using the questions pane on your webinar dashboard. If you have any questions, please just type them into the questions pane and send them our way, and we will address as many of them as we possibly can during the Q&A at the end of the presentation. And last but not least, as you exit the webinar, you'll receive an electronic survey that will ask you to take a minute to complete so we can capture your feedback on today's program. Thanks so much for doing this. It just takes a couple seconds, and we really value all of your input. And now let's get started. It is my absolute pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is Chief Medical Officer here at the Schwartz Center for Compassionate Healthcare and Associate Professor of Medicine at Harvard Medical School. Welcome, Beth.
Thank you, Stephanie. Good afternoon, and thanks to all of you for joining us for this Compassion in Action webinar. As you might know, this past fall, the Schwartz Center hosted our second National Compassion in Action Healthcare Conference here in Boston. Our goal is to convene clinicians, health system leaders, and others who are committed to making compassion a priority in their organizations and communities. The conference was a resounding success. We really had hundreds of healthcare doers, thinkers, leaders, clinicians from across the country and around the globe sharing their insights and innovation in the name of compassion and how we can bring it to all who are caring for patients, families, and for each other. And I want to remind everybody that our next conference is actually going to be here in Boston again, June 14th through 16th, and you'll see another announcement of that towards the end of this presentation. But today's speaker, Liz Métraux, was one of our wonderful speakers at that conference, and we're really excited that she accepted the invitation to join us here today. So let me introduce her. Liz Métraux is a writer and a researcher who spent the last several years traveling across the country, studying how to create a more connected, inclusive, and purpose-driven clinical workforce. She's the founder and CEO of Women Writers in Medicine. Her work has appeared in Stat News, in the New England Journal Catalyst, Modern Healthcare, and more. And she speaks regularly on issues of burnout and joy, vulnerability and power, and diversity and equity and community, which is what she's going to be talking to us about here today. Welcome, Liz. It's so fun to have you here.
Such a pleasure. Thank you, Beth, and the Schwartz Center for having me. I'm delighted to have the opportunity to present. And I will say that as an evangelist of community, webinars are a little challenging for me. So I would encourage folks to jump into the chat feature, ask questions, engage as much as you can. So to get started, as a healthcare event, I am obliged to start with my disclosures. First, I am not a clinician. Much unluckily for the clinicians on the call, I actually study clinicians. So as a writer and a researcher, I've spent the last several years studying what makes you tick and thrive and burn specifically out, and what makes you fulfilled. And disclosure number 2 related to that is that much of that study has been funded by Optum Care, which is a subsidiary of United Health Group. So Speaking of what makes you burn, I want to begin by asking folks to share some of the factors that contribute to your own professional frustration and malaise. So think about your last rough day, and we'd love to hear what some of those challenges were. You can just type them in the chat box.
Okay, thanks guys. Keep them coming. This is fantastic. So what are some of the challenges you encounter on a day-to-day basis? Oh, now they're coming in. It's all starting to happen. Okay.
Oh.
Okay. It's an onslaught. Liz, are you ready?
I am ready.
Yeah, so we're seeing conflict is a challenge. Last minute changes. Too much on my plate, excessive hours. I'll just share a few with you and then you can weigh in. More unexpected changes, inability to move simple some things, requests forward. This is a long one that's not, whether supplies or payment, etc. Colleagues who are not well equipped to do their work, and we'll stop at job performance. Thank you all for your input. Liz, what do you think?
Oh my goodness, EMRs didn't come up?
Not yet?
Oh, they're coming. That's like the next layer.
More traumatic events in the ED.
Yes, interesting, interesting. Okay, so it's funny when I ask that question, I do get a variety of answers. And Anna, you can advance the slide. Your responses look something like this, right? So when we look at factors fueling burnout, there are myriad responses, right? So years ago, I was working at the National Institutes of Health in a role that focused on understanding the workforce. And in that case, our workforce at NIH was right around 50,000 researchers and staff. And we were specifically exploring issues of diversity and inclusion, and by extension, retention, attrition. So what makes people stay in environments, what pushes them out. And this was right around the same time when the topic of burnout specifically was gaining a lot of traction. And we saw Tom Bodenheimer write on the quadruple aim and adding this notion of wellness to the triple aim. And the National Academies of Medicine were raising awareness and establishing the collaborative to advance clinician wellness. And all of this was sort of circling around this space of more and more reports that providers were not doing well, that we were facing a workforce in crisis, that more than half of providers were experiencing symptoms of burnout, dissatisfaction, due to increased staff turnovers. It was leading to clinical errors, unprecedented levels of depression, highest rates of suicide and suicidal ideation among any profession in the United States. So all of that was happening in the workforce. Meanwhile, for the patient population, we were seeing this shortage of healthcare professionals, a coming gray tsunami, an elder boom, and calls to expand clinical expertise and practice into places like social determinants of health and all the manifestations that entailed. So there were these alarm bells going off. We were seeing these factors that were fueling burnout, the incredible systemic challenges that clinicians were up against. So a lot was happening, but I want to ask now another question, and that is, tell me about your last best day. Tell me about when you felt most fulfilled in your work.
All right, everyone, bring it on. Let's see what you've got. Okay. Thanks, Kathy. You're the first one, both of them.
Come on.
Oh, superstar. So when do you feel most fulfilled in your work? We've got some themes emerging here. So one person said, when I was able to make a difference. Along those lines, I helped a client, and when I'm recognized for the work that I do, one of our attendees, so now they're all coming. Look at you all. You take a little time to get up. Okay, more goals were met than were not. So it's relative. Interesting. People put aside their own agendas and focused on the issue at hand. And I'll just share one more, although these are so great. When I have gold star patient care.
Wow, that is awesome. That is awesome. Okay, so there I was exploring provider burnout and all of the dissatisfaction. And I was pounding the pavement in nearly every state in the country except for Hawaii, because if you're burned out in Hawaii, I cannot help you. And this really interesting pattern emerged, the same pattern that just emerged, right? So I should note that I am actually a rhetorician by training. So I study language. I am trained in language and persuasive language, to be exact, but really how people intonate and the ways in which we use emotive and cognitive language, right? So as I was exploring burnout across the country in all its myriad forms, I heard people rattling off long lists of cognitive drivers for dissatisfaction, the very same things that we just heard. Toxic workplace, dissatisfaction in a variety of ways. When I asked the question, what made folks happy, or more specifically, what made people fulfilled, I got a singular emotive response. It was the sense that people felt deeply, deeply connected. So Tolstoy posited that all unhappy families are unhappy differently, and that all happy families are happy in the same way. So across thousands of interviews, age, stage, geography, identity, I kept hearing from clinicians this deep longing for connection. Specifically, a yearning for connection, and you can advance the slide, to peers, patients, and purpose. Not rocket science. Actually the opposite. So we're not talking about the radical here, but actually the elemental. So we're human, and we're driven to connect with humans. Humans are biologically wired to be in relationship, and it turns out, crazy, providers are also human and desperate to be in relationship as well, and feeling increasingly distanced from their call to be in relationship with their peers, their purpose, and their patients. Relatedly, and you can advance the slide, being human in 2019, actually kind of hard. What's going on in our clinics and with our clinicians is a reflection of what's happening in our communities. And clinicians know this. I mean, as goes the community, so goes the clinic. What all of the maladies, the challenges that show up day to day for folks shows up every day. Everything from food insecurity to income inequality. You see this all the time. So also does loneliness and social isolation. So when we think about what's manifesting in the clinics, loneliness is a key driver for so many of the maladies and the challenges that we're seeing. Now, fortunately, we're also seeing an increased attention being paid to the crisis of loneliness and isolation. And I will make a quick caveat that, isolation is the objective measure of how large a person's social network is, and loneliness being the subjective perception of how a person feels. The former is a risk factor for the latter, and the latter touches 1 in 3 older Americans. I mean, that's stunning, right? That 1 in 3 Americans feels a sense of loneliness and disconnection. Former Surgeon General Vivek Murthy calls loneliness the greatest epidemic of our generation. It's as prevalent as obesity. It's even more deadly, as risky to health as smoking 15 cigarettes a day, and actually shortening our lifespan by nearly a decade. And doctors know this. Doctors know the risk of social isolation more than anyone. It's why systems leaders like Sachin Jain, the head of CareMore, are exploring ways to push for the prescription of friendship through interventions like phone calls and home visits and encouragement, connection to community-based programs. Social isolation, in fact, is the leading cause for hospital readmissions. So you get it. You get how critical this issue is. And some countries are even starting to get it. So New Zealand, the UK, are establishing entire cabinet level positions to address loneliness. In fact, just a few months ago, the UK Ministry of Loneliness launched a campaign to destigmatize social isolation following this really incredible data set that they released. 3 in 4 adults in the country regularly felt lonely. 60% of urban dwellers felt alone, and a full 4 million older folks in the country listed television as their main form of company. So, and this is all coming at a time when chronic stress is at an all-time high. Suicide rates have reached the highest levels since World War II. Hospitalization for suicidal thoughts and actions have more than doubled among young adults. Senator Ben Sasse wrote in a really powerful book called Them, Why We Hate Each Other and How to Heal, that we are killing ourselves, both on purpose and accidentally. These are not deaths from famine or poverty or war, but we are literally dying of despair. So when we think about being human in 2019, it is challenging. It is really challenging. I remember telling my daughter at one point, I was telling her the story of, or the recent report on clinicians spending 2 hours of tech time for every hour of patient care. And she was on her phone when I was sharing that. And I thought, wow, we're all spending 2 hours of tech time, screen time for every hour of FaceTime. So, what we see in the clinic is very much representative of what we're seeing writ large. You can advance the slide. And yet, what's good for the goose seems insufficient for the gander. So far too often in medicine, we hold ourselves as clinicians to a very different standard than we hold our patients. So all this data, the impact of social isolation and fragmentation and how that plays out in health outcomes and levels of satisfaction and fulfillment. And yet, rather than addressing burnout, so depersonalization, isolation, overwhelm, all of that through the evidence-based interventions like peer support, and indeed the Mayo Clinic credits a year-long institution-wide community building effort as the foundation for a system charter that led to improved staff morale. Instead, the current MO when we address burnout is that we isolate and then we're punitive in our response to staff dissatisfaction, which is crazy, right? I mean, we can't imagine encouraging a patient who is suffering from depression or burnout to go home alone, right? To listen to music or sit on a yoga mat, like during a moment of real need. But we do it all the time to each other. So again, we hold ourselves and our patients to different standards. Because we're data-driven people, we also know that we co-regulate. So it's emotional osmosis, so to speak. We regulate our feelings and our attitudes based on the company that we keep. So when individuals suffer from or going through something hard, we suffer from burnout, depression, and I will get to I'm conflating the two, and I'll get to that in a moment. But when we're in a moment of need, it's far more effective to socialize than to stigmatize, right? So we bring people in so that as we the process of healing becomes one of co-regulation to increase the levels of wellness among those that we hope to serve. So as I mentioned, I'm using burnout and depression interchangeably. They are not the same thing, and I want to be really clear about that. And they are multifactorial and distinct diagnoses, noting that we're in a sort of self-selected pool of folks. It's easy sometimes to use them interchangeably, but just wanted to call that out. They are distinct diagnoses. So to the slide in front of you, I want to just talk a little bit about what we know about the power of connection. First, connection buoys fulfillment. And that is not speculative. That is a wide body of data. We simply feel better in the context of relationships because we are born to be in relationship. But I also want to add that it's not just capital R relationships that matter. More data is showing that weak social connections can be just as beneficial to health as strong ones, which is a little bit surprising, but also incredibly instructive for those of you who run clinics. I call these ambient relationships. So the barista at your local coffee shop who knows your order, a fellow commuter on your train who rides the 810 every day, front desk staff you always greet with the same compliment about his tie. These kinds of relationships are in fact relationships that signify our position within a tribe, within the context of a community. So they're sort of scaffolding, and they are placemaking and place reinforcing social ties, and they're vital. So when you consider how you integrate community into your clinics, being mindful of the various ways we connect becomes really important. It's not always the capital R relationships. You don't have to have a best friend in your clinic. Creating practices, systems, workflows that optimize casual or superficial interactions can be really valuable as well. Second, if you want to advance that, connection improves communication. So we are simply better communicators when we feel seen and heard and connected. It stills the reptilian brain. All right, so we listen more intently, we're slower to react, we're more empathetic, we're more willing to compromise. I recently wrote a piece on the correlation between isolation, social isolation, and incivility. And we're seeing that unfold in our country in a whole variety of ways. But when we have increased social connectedness, we see increased civility. That provides more space for learning, sharing, and empathy. It fosters understanding. And that is both good for the third and fourth bullets on this case for compassion, for connection, culture spread, and patient care. I'm going to talk about both of those in just a moment. And lastly, incredibly crucial as we move into the business case for community, I want to make an important point. So I'm speaking to you about the individual in all of this. Also, there are serious, untenable systems challenges that we have to do to have to confront to really create sustainable, meaningful healthcare reform that serves both patients and providers. So providers cannot address systemic burnout on your own. And that is why community is perhaps the most important tool for clinicians to leverage. Anna, if you want to go to the next slide, because critical mass yields collective action. And I have seen it time and time again. So this is not, when we talk about community building, this is not a kumbaya moment. This is not some exercise in friend making as an end to itself, though that also has enormous health and wellness benefits. The process of community building done well is about coalition building to advance change making, and community has a unique power to accomplish that work. And all of that combines to make for really good business. So I want to talk a little bit about the business case, and then we're going to get into the weeds of like, how do you do this work? And I always pick on my dear friend, Dr. Nick Nguyen of Beth Israel Lahey Health. He and they are one of many, many institutions across the country who have piloted initiatives to foster community, and the return has been pretty exemplary. A couple years ago, when he and I first began working together, he was new in leadership, like so many of us, and he began with a baseline evaluation of well-being. He knew that his team was really, really not doing well. And physicians in the network of family medicine practices were surveyed, and it was found that just 1 in 5 of those physicians intended to stay in the practice. So about 80% had an intent to leave within 5 years. Now, that was attributed to a range of issues. Some of them were professional, some of them were personal, work compression, the whole gamut. But should those numbers play out, that would cost the average clinic, conservatively, over $2.6 million in replacement costs based on internal estimates, right? So Dr. Nguyen was successful in getting $10,000 from leadership to pilot a series of quarterly dinners with family physicians. So 10,000 for about 6 to 8 clinicians. About 60 to 80 clinicians showed up at the first dinner. And 1 year later, the intentional construction of community, what he had done, and it was in people's homes, it was renting out a local restaurant, lots of different ways that he was able to do that. The intentional construction of community had doubled the intended retention rate when they did a follow-up survey, with more than half of clinicians reporting an intent to stay. And further, the actual attrition rate fell to less than 5%. So it was about 13% to 5%. Huge savings there. But even more important to note was that the real shift in that whole process wasn't just in behavior, people occasionally coming together and a fun dinner in the fall. It was a shift in attitude, right? So when family medicine clinicians saw the value of forming community, they sought out more opportunities to engage, evidenced by the fact that attendance at voluntary gatherings increased with every subsequent event. There's now this incredible primary care innovation network here in Boston that they have been very critical in advancing. And with the support and modeling and participation of leadership, then clinicians felt increasingly comfortable being vulnerable and authentic and connecting with peers through these gatherings and others. So the effort was truly a game changer. And at $500,000 in replacement costs per physician, the ROI was solid. So more companies and clinics are jumping on board. You can advance the slide. I mentioned the Mayo Clinic, and Optum Care is the next example that I would love to share. And I should note that Optum Care is the nation's largest employer of clinicians, and they are fundamentally reshaping how they think about the ROI and think about, provider wellness in order to advance community and connection across the system. We have worked closely with their teams to implement, evaluate, and scale community as a central tenet in their work to develop culture. And that's what I want to talk about next. So the traditional model of organizations, and when we talk about the ROI and the business case for developing community-based initiatives, has been that, culture's on top. Well, if organizations think of culture at all, culture is at the top, with sort of 3 loosely defined buckets below. So there's recruitment and retention, there's leadership development, and there's wellness. Again, if they think of that at all. It's top heavy, it's corporate led. What we've seen through community efforts, however, is a co-creation of culture that is sticky and self-reinforcing and really, really contagious. We know Behavior Change 101, positive contagion is a powerful phenomenon. That is the organic spread of positivity, right? So we take just take the findings of a, report in the American Psychology Association. People with happy partners are significantly more likely to report better health. So if we can create systems, and you can advance the slide, that support positive contagion, and this is the model that I'm seeing more and more organizations use, where individuals are able to influence the culture to support recruitment, retention, leadership development, wellness, that positive contagion really spreads. And you can advance the slide again. So it becomes self-reinforcing and particularly contagious. We have been working in clinics and systems across the country. And it's been really phenomenal how after piloting initiatives at just a handful of sites, we're seeing clinics across the country connect on shared passion, best practices, professional pursuits. And while the data is still outstanding, but leave it to United Healthcare, we will have lots of data and it will be rigorous. We're excited to share the results of the year-long work in early March. So, having gone through that very long-winded sort of description of where we're at in the case for community, I want to talk a little bit about how we build community in different systems across the country. And actually, Anna, you can go ahead and just like put all of the stuff on the board. So there are a number of powerful models that we're observing, and we'd categorize them in two big buckets. So first is the patient care bucket, and that is a space where we see a couple important characteristics. They meet during the workday. While connection and psychological safety are at their core, the intended outcome is really to support clinical uncertainty in the process of navigating clinical challenges. Balance groups, practice inquiry are just two. There are a number of different iterations of ways that you can bring your clinicians together on a regular cadence to connect and just be vulnerable. And that's a huge lift. I mean, even for a clinician to say, I'm really not sure what to do with the patient, is a lot of progress. So we're seeing a lot of models emerge in the patient care space. Again, at their heart, they're really about connection. And then likewise, we're seeing a number of models in the provider care that are chiefly about provider care. I love putting Schwartz rounds right at the top of that because there's so much that Schwartz rounds are doing to advance provider wellness. In addition to Schwartz rounds, narrative medicine, narrative leadership groups are really critical. And then a lot of the less formal models, so book clubs, storytelling nights, support groups. There are also some really specific peer support interventions that are designed to follow critical incidents like traumatic loss of a patient, mass casualties. In fact, we're studying some of those models through the Schwartz Center to understand how best to support individuals that have experienced mass casualty events. Regardless, there's a few characteristics that are pretty consistent in those various models. And I will say, what's important to note, and I'll just very briefly on models that support folks during crisis, is that it's really important to have the infrastructure of peer support hardwired into your clinics so that when events do occur, you have a system and the psychological safety to respond to that. And I'm curious, so folks are seeing this list. This is not comprehensive, but are there other models that you're using, or folks on the line engaging with community networks, groups in your own clinic?
Okay, so we're turning it over to all of you. Kathy, I'm talking to you. But tell us, what models of community are you guys seeing implemented or what are people talking about even? Are you familiar with any of these that Liz describes, or are there others that you've explored or thought about or heard about that have piqued your own interest? Of course, Schwartz rounds. Thank you so much. A processing group for oncology fellows. That's interesting. Very specific, run by clinical social work. Um, debriefing groups for new nursing staff. So both of those thinking in terms of your specialty or your discipline, your profession. Narrative medicine lunches, including today. Fantastic. I'll turn it over to you, Liz. I want to pay attention to the clock. Thank you, everyone.
No, this is great. It's interesting there as we have continued to study this work. There are so many fantastic models out there. Um, and I want to talk now about some of the consistencies and the do's and don'ts. What we found as, regardless of the model you adopt, some of the things that are particularly important to be mindful of. So in the dues category, and by the way, for folks that had interesting or new models that were not listed, I do encourage you to reach out. I would love to learn more. So for the dues, a couple things to be mindful of. Know the business case. We talked about this just briefly, but it really helps to partner with your CFO. I know that can be scary terrain, and other folks to really develop, a short pilot that can help to establish the ROI on these on your community building efforts. Ask what folks need. I think that too often we go in with assumptions and aren't quite as willing to, we sort of assume what people need in the group, and sometimes those can be very surprising. I remember hosting a group in Colorado recently, and the biggest barrier to participation was actually childcare. So being able to think about community building efforts and connection and being mindful of what people are needing as barriers is really important. I tend to get a lot of pushback on the next one, and that's with affinity groups. So in the push for care, team-based care and more collaborative work environments, we tend to kind of put everyone in a room and hope for the best. The reality is the challenges faced by women in medicine, with early careerists, with people of color, are very different. And being able to establish some norms and practices for psychological safety within smaller affinity groups is really, really critical. So it also narrows the aperture of a pilot, which can be really important to prove efficacy that you can give back to your CFOs to demonstrate ROI. So I'd start with your affinity groups. At least having one or two shared characteristics can be meaningful. Protecting time. I hear again and again from folks that it's one more thing I have to do. So finding ways that you can incorporate it, protect the time, integrate it into CME or other activities can be really valuable. That was a lesson learned from Beth Israel that would be useful for other clinicians. And lastly, have a facilitator. It's easy to think that we can do it all, and that being particularly close to the challenges help us to elucidate some of those concerns. The reality is that it helps to be a couple steps away and have someone move the conversation along and ensure that there's a particular takeaways, calls to action, and follow-ups, and you don't kind of get stuck in one space in the dialogue. And as far as the don'ts, there are several. Don't go it alone. You have an incredible community yourself, so I would reach out to them, tap into them. Again, I talked about assumptions, and it always bears repeating. Don't make assumptions about needs. Sometimes needs can be very, very different than what we assume. So please reach out to folks and ask. Often when we are in the context of community building, events, team builders, dinners, things like that, very specific concerns arise. And it's incumbent upon that third-party facilitator to bring those to leadership. So failure to follow through is something that is it can really stymie progress on any kind of community building efforts. Frankly, any kind of burnout mitigation work. Failure to follow through is a challenge. And lastly, don't bitch. And I say that very candidly. So often the first few minutes of gatherings can be a wonderful, wonderful space for catharsis and connection. That's just an unburdening. But that unburdening needs to turn into coalition building and agency making. So that's where a facilitator can be really critical to say, okay, we've spent 5 minutes in this space. Let's now move on. Like, what lessons can we learn from some of the shared pain to actually move the discourse forward? And that about wraps it. Goodness, I don't even know what my next slide is. But would love to kind of open up, and I'll pass back to Beth. But I know this is a lot of content and a lot here, but really eager to hear folks' thoughts.
So Beth, are you unmuted? We might be having some audio issues here at the Schwartz Center. I'm going to blame the snowstorm that's on its way here. But I do want to invite everyone to share any questions that you might have for Liz, to share anything interesting that's been happening at your organization. And I think, I'll kick it off until Beth resolves the audio. But I'll kick it off, Liz, to ask just what do you see as sort of, I know people on these webinars, people always say, what can I do? So where would you start? If you're on this webinar, you're working within a healthcare organization, I think in a lot of ways we're preaching to the choir, making the case for this work. Where is a good place to start? So sorry.
Oh, no worries, no worries. So I would say a good place to start is to find a handful of folks that are like-minded and passionate about the work of wellness, and get them together over dinner. I'm a Southern girl, so we don't have hard conversations without food. And I've written on this quite a bit, but just to fellowship and find the one or two places where you feel like you may have some agency and some opportunity to influence decision making. So start there. I would also not underestimate unusual partners. I am always amazed at how often when I speak to C-suite CFOs, folks like that, they feel this sense of disconnection from the clinical workforce and the frontline staff. So if there are places where you can engage decision makers on the financial side to say, hey, we're going out to dinner, it's a handful of us, we're really interested in doing more on the wellness front, like, can you help us make the business case? Like, can you help us think through how we might navigate the ROI? I guarantee you that more financial leaders and institutions are willing to jump into that.
Thank you. That's fantastic advice. We see the same kinds of unusual partnerships certainly emerging around the work we do here at the Schwartz
Yeah.
Center. And so I have Beth now next to me because we did have audio issues in her office.
Sorry.
And we've got some great questions coming in. So I'm going to leave it to Beth to share those with you.
Thanks. Sorry, you guys. I was interested in the data that you presented, Liz, and I think a lot of people were actually, in terms of the return on investment, because we know that that speaks to senior leadership. I have a couple of questions related to that. One is, for people who don't have the backing or the research funding to do this kind of work, how do you do that within, an existing organization with no external funding available?
I would partner with your CFOs and your HR, your leadership development. Everyone's scrambling to figure out how to keep physicians in place and clinicians in place. It is $5,000 in replacement cost for a physician in particular, but that's also ancillary to clinicians. So everyone has a vested interest in keeping folks well. And that's where I would say, learning the language a little bit of finance and learning the language of your leadership development teams or professional development teams can really behoove you. But the notion of going it alone to figure out or trying to like in your own clinic walls to figure out how you can get research funding or dollars to do this work, I would avoid doing that. I would actually bring it to leadership and have the conversation to see how you can best support the workforce.
Yeah, and I mean, most organizations now, I think, have wellness, well, not all, many have wellness officers, engagement, well-being, champions. So it would be great to work with them.
And often that lives underneath diversity and inclusion efforts. So you might end up getting creative in the same way we have creative partnerships that are maybe external. There are some really wonderful creative partnerships that can be internal. We work with an incredible team at Rush University, and all of their wellness efforts are actually through their diversity and inclusion office. So so trying to kind of do a little stakeholder analysis. You do the same thing of community mapping if you were in sort of the community organizing space, but do a little stakeholder analysis and see who's paying attention to the issue that you're focused on and trying to build community and what matters most. One of the things I mentioned in my comments that we hold ourselves or hold clinicians to a different standard as we hold our patients and we hold our practices differently too. Like, when was the last time you did motivational interviewing with your CFO to say what matters most? Like, what matters to you? And then navigate a conversation around what matters to you as clinician to kind of meet in the middle. We don't do a lot of motivational interviewing with our peers or with our supervisors. That skill set is really, really valuable when you're trying to build coalition to do the meaningful work of community building. So I would use the skills that you already have and identify those unusual partners to do a little motivational interviewing.
Yeah, and to the original point, find the homes that are working there and and just have a conversation to see how this might be put forward. I guess people are really interested in following up on your data once it's published. Do you have any ways that they might be able to do that?
Absolutely. So much of that data is going to be released through Optum Care, and we will certainly send it out. I mean, because we consider Schwartz Center a wonderful partner. Hopefully, we will find a way to make sure that data is shared via newsletter or something to that effect. But it will definitely be out in early March. That just indicates sort of the correlation between community building and retention and wellness.
That's great. And also hopefully at the conference in June.
Yes. Oh, yes.
Oh yeah. Um, so a couple of more questions here. Everybody's worried about finding time. How do you find protected time? How do you convince people that this is essential? I know we've already talked about the business case. And then again, there are the division and department chairs and the nursing managers and directors who, you also have to convince. So then how do you get to those folks, and how do you find that time? That's the question that was posed here.
Yeah. So I'll answer the more straightforward question, and just time. Like, how do we
Mhm.
find time? How do you find time for relationships? Um, and so twofold. One, you make it, and when you make the business case and you set the ROI, that's part of that conversation to ensure that, like, part of that build out is that we have protected time. So whether that is an hour huddle every other week where you don't have patients, when you start to demonstrate the ROI, and that takes a bit of a lift, then it can push, much like Beth Israel. Beth Israel is such a great example. When they started to see the ROI play out, they saw the need to protect an hour, 60 minutes of clinicians' time every other week to meet in a huddle. That's a lot of time. That's a lot of lost revenue if you were from a CFO perspective, and yet the return on that was extraordinary. So it's partnering to make sure that you have the ROI case. And then there's a lot of ways that we build in the practices, so it doesn't take a lot of time. So say it's 8 hours a year, okay? Like if you had a quarterly dinner that took 2 hours a quarter. So you're talking 8 hours a year, and the return on 8 hours a year of being able to then minimize some of the challenges and the work frustration and all of that throughout the course of the year, because you have greater psychological safety. You start playing with the numbers and the return is pretty strong. I get that time is hard. And managing that is really, really challenging. That is where you cannot go it alone. And it's really important to partner with people that can monetize that and think about that from a financial perspective.
Yeah. Oh gosh, it's so hard, isn't it? I hear such a related question too. We have nurses who often ask for support groups, but when we offer them, no one shows up. So almost like you're trying to prevent burnout and support well-being, and yet the efforts that you're doing that are taking them away from home, and
Yeah.
it's such a situation. So how do you respond to that?
So I would say, it depends on timing of when you hold some of these things. So two things. One, that's where asking for what people need. People didn't show up when we were doing these sort of dinners and connection opportunities in a site that we were working in Colorado until we offered childcare. And what we realized that the people were younger, right? And they had kids. And so, asking them to do something after hours was particularly when they were not, they didn't pull in doctor salaries. So that it became a barrier in a lot of different ways. The other thing, I love Simon Sinek had this great dialogue with a man, and he was talking about the moment he fell in love with his spouse. And they bantered back and forth, and the guy didn't have a response to when he fell in love with his spouse. He said she just kept showing up. And the point that Simon Sinek was making was that consistency matters, right? That we just keep showing up. And so I think when, one of the biggest barriers that I have heard from folks who are starting community building groups is, what if nobody shows up?
Yeah.
What if it sort of throws us back to fourth grade, like middle school dances, like asking someone out. Like, what if I'd ask someone to dinner, or a group of my colleagues to dinner, and they don't come? Egg on face, and my encouragement is you just keep showing up. So, when you set this is why ambient relationships have such great health benefits, because they're consistent. So when we say, you know, at the first Monday of every month, we're going to have a lunchroom, a brown bag lunch, and somebody's going to talk about a book they read. You might have the first 2 months and it's just you and somebody else, you know, but you keep showing up, and then it establishes a routine that eventually people start showing up, and consistency really, really matters. And when it comes to responding to people in times of trauma, when they know that you're going to be there, regardless if they're the only person there, that really matters.
Yeah. It builds trust too. It's really
Yeah.
with the patient, you know, with relationships with patients as well. It's
Yeah, you're always there.
being there, right? Exactly, and following through. So let's see. We have time for one more question. So I had a question, and for me, it's sort of a little bit more theoretical, but I was really interested in that model about how community building influences culture.
Yeah.
Through positive contagion. So are you doing network studies? How are you getting to that conclusion?
Yeah. So I'm going to have to credit Dr. Curtis Mock with that, who is the head of workforce strategy for Optum Care.
Mm-hmm.
And really taking the quadruple aim and spinning it in a way that serves workforce wellness. So, you know, we sort of lobbed Tom Bodenheimer, and I'm such a fan of his work, you know, added wellness onto the triple aim, and that was really powerful and important work. Also, it shouldn't be an add-on, right? So we're seeing institutions and Optum Care being part of that, saying like, okay, what if we built that aspect of the model as its own thing? So doing a quadruple aim for workplace wellness, and they're testing it. Beth Israel, Dr. Nick Nguyen is doing the same kind of work to say like, what's the right balance of all these different components to make sure that we're able to retain, recruit a really inclusive workforce that feels seen and heard, and they are well. So more to come on that, but it's really exciting work. I'm excited to see how community building actually shapes culture versus the other way around.
Yeah, that'll be super fascinating. Really looking forward to it too. Well, I am feared that we must wrap up the webinar, because there's like a million more questions I'd like to ask, and I'm sure so would our participants here, but we must end. And I just want to thank you, Liz, for this really, really interesting presentation. And, you know, it feels so possible. You know, I think that's part of the positive message and what you've shared with us today. It is possible. And there's data to support it too. So let me turn it back over to Stephanie to close us out and to encourage everybody to fill out the feedback and evaluation form so we know how to improve.
Oh, great. Thanks, Beth. And thanks, Liz. For someone who is fairly skeptical of the webinar format, you did a great job eliciting a sense of community here today. So thank you for that. And thank you, everyone, for joining us today. Thanks for taking the time out of your busy days to participate in the webinar. I know that all of you are doing phenomenally interesting work in your own world. So I just want to remind everyone of our upcoming Compassion in Action conference. We have a request for abstracts open for that now until technically next week, but hopefully we'll extend it. So if you have any work you'd like to share with us at the conference, please, absolutely. We'd love to hear about it and to consider it for presentation. Until then, I will leave you all, and we know you're busy. We hope you'll join us for the next Compassion in Action webinar in February. And again, please take a minute to fill out that survey form, and we'll hope to see you soon. Take care.